In opioid-dependent pregnant patients, the opioid substitution therapy with methadone or buprenorphine is the recommended first-line treatment. Methadone is a long-acting oral opioid. It can also be used parenterally, and it's used to treat opioid withdrawal, and also used in some forms of very chronic severe pain. Buprenorphine is a partial mu agonist, and what it does is it displaces other opioids from opioid receptors due to high receptor affinity, and what happens is it precipitates withdrawal since it does not produce the same receptor activation as the full agonist would on the opioid receptor. Methadone helps because it's long-acting and it'll prevent any type of withdrawal that will happen. It decreases any cravings for opioids, and it also reduces any of the euphoric effects that you would have with opioid use. The methadone can be used throughout the pregnancy. However, you have to make sure the mom has other services of care such as social work or counseling. The dosages are going to increase for the methadone over time because the metabolism also changes in pregnancy. If your patient has been unable to quit opioids, it's really important to recommend this medication-assisted detox because the patient is at very high risk for relapsing. And this is very dangerous for the fetus because you can have multiple withdrawal episodes from having very erratic behavior of intoxication, and it causes a lot of fetal stress. You do not give naltrexone unless the patient has been completely detoxed and they have been opioid-free for a while. Additionally, if the patient is pregnant, there hasn't been much evidence of using naltrexone, so stick with methadone or buprenorphine. There's other forms of opioid withdrawal therapy where you can use a methadone-buprenorphine combination.